drug is necessary and why this is essential in our population. So, as we all know, antimicrobial infection is a global crisis. Mortality is high, approximately 1.3 million deaths in 2019, 2020, and we have the 10 million projected to die by 2050 from the AMR, that's multi-resistant microbials, and it kills more people than cancer and RTA combined together. So even in India, 2 million deaths are projected by the year 2050. So what causes the problems? What are the AMR pathogens? These six, extended by from IDSA, this is the extended spectrum beta-lactamase producing enterobacterials, AMC beta-lactamase producing enterobacterials, carbapenem resistant enterobacterials, of which I will be talking a little bit today. Pseudomonas aeruginosa, DTR Pseudomonas aeruginosa, carbapenem resistant Acinetobacter baumannii with a notorious name crab, and Strainotrophomonas maltophilia. So the enterobacterials, as you know, which contain 7 groups of dominant bacilli, the most clinically relevant being Enterobacteriaceae, which includes Escherichia, Klebsiella, Enterobacter, Citrobacter, Salmonella, and Shigella. So, Morganellidae family, also Proteus, Morganella, and Provincia, and other genera, Serratia, Hafnia, and Yersinia, are also part of the enterobacterials. So, how will you define carbapenem resistance? CDC defines carbapenem resistant enterobacterials as bacteria within the enterobacterials order, which are resistant to at least one carbapenem or that produce a carbapenemase enzyme. So, there are 2 types of isolates here. So, one is a carbapenemase producing isolates, which the resistance is due to the presence of carbapenemases, and the enzymes are produced with the bacteria that inactivate carbapenem antibiotics, and typically other beta-lactams, including penicillins and cephalosporins. While non-carbapenemase producing carbapenem-resistant enterobacterials, it's due to the acquisition or upregulation of a beta-lactamase gene. There is coupled with a mutation of a porin gene that limits the ability of carbapenems to enter the bacterium. So this is a well-known Ambler classification of beta-lactamase enterobacterials, which includes both ESBLs, extended spectrum beta-lactamases, as well as carbapenemases. So of which I'll come to that. The class A, which includes penicillinases, cephalosporinases in the TEM, SHV, and the CTXM, what is exclusively sensitive to ceftactin, CTXM groups, which do not inactivate carbapenems, and will is additional groups, as we you see here. There is a KPC, GS, imipenem hydrolyzing group, and NMCA, which contains which are carbapenemases. So isolates within this class are characterized by their hydrolytic mechanism of beta-lactam inactivation, which is an active site serine at position 70. And the most clinically important, probably the most widely seen in US, is Klebsiella KPC, or the Klebsiella pneumonia carbapenemase group. And genes that encode is basically plasmid-mediated resistance in KPC, and it's recovered from multiple regions of the world. So more pertinent to our country is class B beta-lactamases, also known as methyl-beta-lactamases or MBLs, named for the dependence on zinc for efficient inactivation of beta-lactams, and all are carbapenemases. Initially described in Japan in 1991, greatest burden is in South and Southeast Asia. The most clinically important is newly methyl-beta-lactamase, which is described around in 2006 from India. So the gene encoding NDM1 is embedded in a very mobile genetic element, and it's a very complex, very unpredictable spread. And they can be inhibited by EDTA because it's dependent on zinc and not inhibited by beta-lactamase inhibitors. Class C does not have significant carbapenemase activity, also called as AMC beta-lactamases, while Class T is the classical OXA type enzymes because of their preferential ability to hydrolyze oxazoline, of which the most important is OXA 48 type carbapenemase. So this is from the Sentry study, which looked over 20 years of data from different regions, of which the most alarming is to see is in the Latin America, where the carbapenemase is exponentially resistant to Lactobacteria prevalence is exponentially rising, followed by Europe and North America, and finally the Asia Pacific. This again, when all data for the carbapenemase country. So we can see the more in the Americas, the commonest is KPC, while in India the commonest is NDM. There are many areas where OXA48 is, especially after there is OXA48 is more prominent, and there's many of the carbaminomases, and that should dictate our antibiotic policy as well. So what are the risk factors here? There's prior colonization or infection with a carbaminoase producing strain, recent travel to the countries with high prevalence, trauma, diabetes, malignancy, organ transplant recipients, mechanical ventilation, indwelling catheters, overall poor functional status or severe illness, residence in a long-term care facility, all the risk factors for a carbaminoase infection. So this alarming situation actually led the Infectious Diseases Society of America to run this campaign, Bad Bugs Need Drugs. So 10 new antibiotics by 2020. And as a result, many antibiotics were produced by the pharma, and of which plasmicin is one of them. So there was dalbavancin used for acute bacterial skin and structure infections, tedizolate, ceftriaxone tazobactam for complicated intra-abdominal infections, acquired pneumonias, and urinary tract infections, ortavancin, eravacycline used for again cUTIs and MDR infections, plazomicin used for complicated UTIs, gram-negative bacterial infections, and pyelonephritis, linezolid, telizolid, imipenem, cilastatin, relibactam, pretomanid, lefamulin, and cefdorozole used for complicated UTIs. So where does the action stand? So many ceftobiprole is mainly using class A, class B, and class D enterobacterials, and also Acinetobacter and Stentrophomonas multifilia. The ceftazidime avibactam for class A doesn't act against class B. And Pseudomonas aeruginosa when on those sensitive strains, ceftriaxone across most of these organisms. Meropenem avibactam preferably for class A and doesn't have active against class B or class D. The same with imipenem relibactam. Aztreonam avibactam is for the reprise trial that it can act against class A, class B, class D as well as Pseudomonas aeruginosa. And plazomicin is active against class A and class D carbaminomases. Eravacycline is active against class A, class B, and class D, but it cannot be used for urinary tract infections or bacteremias. So when a CRE isolate is confirmed, so if it is resistant to standard antibiotics, the pathway is whether it's the carbapenems. If carbapenems testing is available, it's not available, antibiotics based on prior culture results, geographic exposure, and initial susceptibility results. So if carbapenems testing is available and is positive, is OXA48, ceftazidime avibactam, and alternatives of cefdorozole, tigecycline, eravacycline, and is MBL, ceftazidime avibactam, aztreonam avibactam, and alternatives like cefdorozole, tigecycline, eravacycline, and ceftazidime if it's KPC, the ceftazidime avibactam, meropenem avibactam, imipenem, cilastatin, relibactam, and alternatives cefdorozole, tigecycline, and eravacycline can be used, but most of these drugs are presently not available in our country, limiting our use. So when you use a carbapenem-resistant enterobacterials in uncomplicated cystitis, nitrofurantoin, TMPSMX, bactrim, single-dose aminoglycosides or oral fosfomycin can be used if sensitive. So the higher percentage of CRE clinical isolates are susceptible to plazomicin, single dose, 50 milligrams per kilogram compared to other aminoglycosides. Colistin can be used, but with significant nephrotoxicity that converts to active from the urinary tract, and polymyxin B should not be used because it's not cleared renally. So pyelonephritis and complicated UTI susceptibility is demonstrated. The TMPSMX, cipraloxone, levofloxacin can be used. Ceftazidime avibactam, meropenem avibactam, imipenem, cilastatin, relibactam, and cefdorozole preferred options. And aminoglycoside, of the aminoglycosides, plazomicin is the preferred agent and is shown significantly decreased mortality compared to other agents, as well as colistin. In some of the studies, as we show the EPIC study with covered meropenem, and fosfomycin is not suggested given its limited renal parenchymal concentrations. So outside the urinary tract caused by carbapenem-resistant enterobacterials, if KPC production, suggested approach is a BLBLI combination, the meropenem avibactam, ceftazidime avibactam, imipenem, cilastatin, relibactam. An alternate option is cefdorozole, which is a synthetic conjugate composed of cephalosporin and sidrophore. which binds to iron and facilitates bacterial entry using active iron transporters. So it binds primarily to PBV3 to inhibit bacterial cell wall synthesis. 95% of KPC producing enterobacterials is susceptible to ceftriaxone, but then NDM, where the resistance is varying highly, so ceftazine-azobacterium combination aztreonam ceftriaxone monotherapy can be used. And OXA48 ceftazine-azobacterium is a preferred treatment option. This is the ITSA guideline 2024. So tetracycline derivatives function independent of presence of type of carbapinamases, which achieve rapid tissue distribution following administration, resulting in limited urine and serum concentrations. It is not suggested for urinary and bloodstream infections and can be considered for intraabdominal infections, osteomyelitis, skin and soft tissue infections, and respiratory infections, and tigecycline, eravacycline, and other molecules. And finally, coming to treatment strategies for infections. So consider patient comorbidities, history, and local resistance patterns for empirical therapy. Opt for early initiation of new agents and use all the drugs only if BLBLAs are available. But the fact is that many of these new drugs, especially aztreonam, avibactam, relibactam, are not ceftriaxone are all not available in our country. And there is no role for colistin or polymyxin in CRA treatment. And combination therapy can lead to increased toxicity. And the microbiology labs should be encouraged to identify carbapinamases. So in this setting, especially with the rise in carbapinamase infections and antimicrobial resistance, plasmomycin offers a plausible role in, especially when most of the other antibiotics which are unavailable. Thank you.